So we are going to spend the next 25 minutes or so discussing about progesterone. On the last day of stimulation, the day of triggering final oocyte maturation, and whether it decreases the chance of success. So we are all aware of the association between the LH surge and the rising of progesterone. This happens in the middle of the cycle. It's the signs of the ovulation. Unfortunately, this association also is operative in ovarian stimulation for IVF. So when we started using gonadotrophins for ovarian stimulation in the early 80s, there was no way to inform the human body that the woman is undergoing an IVF cycle. The human body just understood that there were high estradiol levels and, of course, trigger the mechanism for ovulation, LH rise and progesterone rise. This occurred in about 20% of women and led to cycle cancellation and retrieval of no oocytes. So progesterone in those days started to have a very bad reputation. Soon after, in 1984, the game changed and the GnRH analogs were introduced in ovarian stimulation for IVF. This significantly decreased the proportion of patients exhibiting LH rise and progesterone rise to approximately 2%. So this LH-associated progesterone rise, which was very bad for our cycle, was almost eliminated. However, several researchers described a phenomenon reported as premature luteinization. So we indeed avoided the LH-associated progesterone rise, but there were still cycles in which progesterone was elevated. What we mean by premature luteinization, or what did these authors mean, is a rise in serum progesterone levels on the day of triggering final oocyte maturation above a threshold level, which is usually arbitrarily defined. So these two terms, premature luteinization and progesterone elevation on the day of triggering, are in fact meaning the same thing, just to avoid the confusion. So the hypothesis in the early 90s was that in the presence of progesterone elevation, the probability of pregnancy is decreased. It all started with an abstract by Schoolcraft at the 45th annual SRM meeting in 1989. So this issue was in the agenda of ovarian stimulation. Of course, we create a controversy as usually. So a lot of studies confirmed this hypothesis. Progesterone is bad for our pregnancy, but others did not. The literature kept on becoming richer and richer, and at 2007 we attempted to systematically review the literature by publishing a meta-analysis on systematic review and meta-analysis on the issue of progesterone and pregnancy. A lot of studies in the systematic review, but in the meta-analysis there were only 5 studies which were meta-analyzed. The difference, and kept that in mind, was about 10% lower in the progesterone elevation, but this difference was not significant, statistically significant. A next attempt occurred 2 years later in 2010. It was published this year, but it was until 2010. This is a meta-analysis of the effect of progesterone on pregnancy rates only in antagonist cycles. Again, very similar difference. This is the absolute risk reduction, 9% in the patients in the cycles which exhibit progesterone rise on the day of ECG. The thresholds used for this purpose were about 1.1, 1.2 nanograms per ml for all these studies. Now, both meta-analyses, which were both published by our team, supported that progesterone elevation is associated with more oocytes and higher estradiol levels on the day of ECG. At the same time, it was not associated with a total dose of FSH or the duration of stimulation. Meta-analysis is a nice way to approach the literature, but unfortunately it's not without concerns. So we know that this pooling of data was about different patient populations, different stimulation schemes, different kits used for progesterone evaluation, and certainly different definitions for progesterone elevation. Moreover, the sample size in this meta-analysis did not allow for enough power to permit exploratory analysis, meta-regressions, etc. So unfortunately, there were some problems. The issue today of progesterone elevation and its effect on pregnancy is not still resolved. However, as usually, there are researchers which just deny the presence of any association, and there are others which, despite the lack of solid evidence, have already implemented strategies to avoid or manage progesterone elevation, which is not unusual. Although we have published these two papers, I don't think they are very influential ones. I just think that their contribution is that they stir the waters. They made us think what are the important questions regarding the issue of progesterone elevation and what is the literature lacking in order to answer these questions. So the relevant question is, what is progesterone elevation? How we define that? How frequent is that? Is there an association with pregnancy achievement? Is any effect universal, so across populations, across gonadotropins used? Is there a plausible biological or physiological explanation for any effect? And certainly, if whatever effect is there, is it clinically important or not? Finally, are there any ways to control or avoid such an effect? So researchers following these two meta-analyses went back to their desks because it's easy to collect data on the association of progesterone elevation in pregnancy, usually retrospective, but everybody has such data. So there was a tremendous influx of publications following the last meta-analysis. From 2010 to 2012, there were about 27 studies published on this issue. And I think that we urgently need an update, and this is what I'm going to present to you today. So we search Medline, etc., hand search of publications, no language limitations applied until August 2012. Inclusion of studies in which fresh or frozen embryo transfer or transfer with donated oocytes was allowed. The study should provide extractable data on pregnancy rates among women classified as those with and those without progesterone elevation on the day of ECG, and ovarian stimulation should have been performed with gonadotropins and FSH. Studies were excluded if the level of progesterone on the day of ECG affected patient management, and the authors said that, or if different number of embryos were transferred between patients with and those without progesterone elevation. Started with 5,000 studies. Finally, we ended up with 68 studies offering data for this issue. What we are really dealing with, I think, is the largest meta-analysis ever in reproductive medicine. This is 62,700 cycles. I think it's probably enough to keep us busy for the next period. So 63 studies or data sets in fresh cycles, about 54,000 patients, 7,000 patients in FRED cycles, and about 1,300 patients in donation cycles, offering data to answer the questions we are interested in. So how is progesterone elevation defined? It appears that our understanding of what is progesterone elevation has changed throughout the years. So this is the period from 90 to 99, 2000, and 2000 until today. And you see that in the early days, the most frequent definition of progesterone elevation included a progesterone threshold of more than 1.1. But this has changed as we come to the present time. So this is less and less frequently used. On the other hand, 1.5 nanogram per ml is more frequently used nowadays than in the past. Now, how frequent is progesterone elevation? What we are really talking about? Of course, it depends on how you define progesterone elevation. So these are progesterone threshold groups according to this literature we analyzed. So this is the very low one, 0.4 to 0.6, 0.6 to 1.1, 1.2 to 1.4, 1.5 to 1.7, and more than 1.9 until 3. And you can see this is the pooled proportion of progesterone elevation, that as the progesterone threshold group is increasing, so the higher the progesterone threshold we use to define progesterone elevation, of course, the lower the proportion of patients with progesterone elevation. The lower the proportions of patients who are interested in to find the truth. So from 46.7, about half of our patients, to 12.3 when we use a progesterone threshold more than 1.9. The commonly used 1.5 nanogram per ml nowadays leads to about 70% of our patients with a confidence interval of 13 to 21 having progesterone elevation on the day of ECG. If we forget about subgroups, because this is to make data more understandable, and we use the individual thresholds, so we do a meta-regression on the proportion of elevation, progesterone elevation according to the individual threshold, what we see is exactly the same. So as the threshold is increasing, the lower the proportion of patients, the lower the pooled proportion of patients with progesterone elevation. Now, is progesterone elevation dependent on the type of analog used? So if we use agonists or antagonists, does it make a difference for the progesterone elevation? So these are the data collected. This is the agonist, this is the antagonist, this is mixed population. So in this group, there was no antagonist arm. In this group, the proportion of progesterone elevation was lower in the agonist group, 31 versus 56, whereas in the next group, higher progesterone threshold, it was almost the same. Here it was reversed. Because it's difficult to do visual statistics, you need to do a meta-regression, which we did. And what it says really is that there is some evidence, the p-level is 0.051, to show that the proportion of progesterone elevation might be lower in the antagonist cycles than it is in the agonist cycles. So if you want the best approximation to the truth, it's probably likely that antagonists are associated with less patients with progesterone elevation, which makes sense if you just recall the data from Filippo, which showed lower OSATs in the antagonist arm. Now, is the progesterone elevation dependent on the type of gonadotrophin? So we use a LH-containing or not a LH-containing gonadotrophin. The visual inspection of the PE elevation in the different thresholds used in the literature doesn't show much, because this is much higher in the LH-containing, but this is the reverse. Again, this is higher, this is lower. So if you do a meta-regression, you would see that you cannot support that the type of gonadotrophin has anything to do with the proportion of patients showing progesterone elevation on the day of triggering final oocyte maturation. Finally, is it dependent on the type of population analyzed, which was a popular discussion when we talk about progesterone? So here we have high responders, or PCOS. This is poor responders, and this is not specific population, general one. So in high responders, here is higher than compared to the poor responders. This is no comparison. This is again higher. If you do the meta-regression, although the overall model is not significant, if you treat this as an exploratory analysis, you could probably see again that high responders are more likely to show progesterone elevation compared to poor responders. But again, this is just for exploratory analysis. The overall model is not significant, so you cannot support that the type of population is really influential on the incidence of progesterone elevation. So, what we have shown so far is that progesterone is not an infrequent phenomenon. It's about 70% when you use 1.5. Its incidence depends on the threshold used for its definition. It ranges from 46.7 in the very low thresholds to about 12% if you use a very high threshold to define progesterone elevation. For the commonly used, nowadays 1.5, the incidence is about 17% of our patients will show progesterone elevation. And there is some evidence to support that elevation of progesterone might be less frequent in antagonist cycles and might be higher as compared to poor responders. Now, we come to the important question, which is, does it have an effect on the probability of pregnancy? So is progesterone elevation on the day of triggering altering the probability of pregnancy? So these are the forest plots we have created in the different progesterone threshold groups. And these black symbols are the pooled or the odds ratios. And you can always see that in all charts, it's left to the line of 1. So there is always an effect against progesterone. This effect is always statistically significant, with the exception of the first, the very low threshold group, which is just reaching significance, perhaps due to the fact that the study number is smaller. But otherwise, the effect is always there. It ranges. The most important effect is here, 0.65 odds ratio at the level of 1.5 threshold group. So yes, progesterone elevation appears to significantly decrease the chance of pregnancy. If we look at it on a different way, this red line represents the whole population. The blue line is not specific population. These are the high responders. There is no line for the poor responders because there were only 2 studies. So the blue line, which is the whole population, this is the effect which was not significant, if you remember, for the last slide. But even from the first threshold, which is 0.9 to 1.1, there is a significant effect which becomes even more significant, so more effect on pregnancy rates when you go higher to 1.2, but then it seems to be relatively stable. So even if you go to higher threshold groups of progesterone, your effect is not increasing. If you look to high responders, you could see something different. So there is no effect in the 1 nanogram, 1.2, even at 1.5. So the effect in high responders appears to be present only after you cross 1.9 nanogram per ml. So it seems that high responders, let's put it in that way, are more resistant to the usual thresholds that we call progesterone elevation. In order to show an effect, you have to define it to a higher threshold. Let's put it in a more formal way. Is the effect of progesterone dependent on the type of population? Again, model is not significant, but if you compare poor responders to high responders, yes, it seems that there is a difference there, and the effect is less pronounced in high responders. Is the effect dependent on the developmental stage of embryos? Blastocysts are perfect for progesterone elevation. No, the answer is that the model is certainly not significant. There is no evidence that if you do a blastocyst transfer, you will save the chance of pregnancy. Is the effect of progesterone elevation depending on whether the study is analyzed more than 1 cycle per patient? We all know that when we do retrospective studies, unfortunately, some patients will enter the study more than once. And these studies are in this sample size. So we did a special analysis for that, and it appears that there is no difference, there is no influence of that problem, which is known to inflate the P levels. So in this data set, this does not represent a problem, and the same is true about the study design. So whether the study was prospective or retrospective, there was no influence on the effect of progesterone on pregnancy rate depending on the study design. So what we've shown with the previous slide is that progesterone elevation is indeed associated with a decreased chance of pregnancy. The effect of progesterone elevation varies according to the threshold used for its definition. The most intense effect appears to be present when we use a threshold of 1.5 to 1.75. and then the odds ratio is 0.64. In high responders PCOS, the effect of progesterone is present when using higher thresholds as compared to the general population. And finally, the effect of progesterone on the probability of pregnancy does not appear to be modified by the stage of embryo development and transfer. Now, let's talk about secondary outcomes. Number of oocytes, to the right is always the progesterone elevation group, are significantly increased in all thresholds used. So whatever we use for defining progesterone elevation, the arm with progesterone elevation will always have more oocytes. It is true in 3 out of 4 groups, this will just touch in the line, that also estradiol levels will always be higher regardless of how defined progesterone elevation. So in the progesterone elevation group, oocytes and estradiol levels will be higher. The same cannot be supported for duration of stimulation, which was only higher in one group, the lowest one. In the remaining groups, there was no difference between progesterone elevation and no progesterone elevation regarding duration of stimulation. Regarding the total dose of FSH, well, in 3 out of 5 groups, it was higher in the progesterone elevation group. In the remaining 2, there was no difference. So it seems that regarding the dose of FSH, in some studies the effect can be seen, so you need higher doses, you use higher doses of FSH to create progesterone elevation, which makes sense if you remember that you have more oocytes and higher estradiol levels. Again, some conclusions from this. Progesterone elevation is associated with more oocytes retrieved, with higher estradiol levels, does not seem to be associated with the duration of stimulation, and there is some evidence that progesterone elevation is associated with a higher total dose of FSH. Now, is there a plausible biological, physiological explanation for the adverse effect of progesterone elevation on pregnancy? Is it an embryonic factor? Are embryos compromised? Well, according to this meta-analysis, they are not. These are the odds ratios in frozen thought cycles. So these are the pregnancy rates in cycles in which embryos were originated from cycles in which progesterone was elevated or not. So odds ratios exactly at 1. So no evidence that this is due, the effect of progesterone on pregnancy, due to an embryonic factor. The same is true for the donation cycles. Again, the odds ratio in this sample size do not suggest that there is an embryonic effect of progesterone which leads to the lower chance of pregnancy. So no evidence is provided from FRET cycles that embryos originating from a cycle with progesterone elevation are less capable to implant than those originating from a cycle without progesterone elevation, and the same is true for donation cycles. Now, why is then a lower probability of pregnancy in the presence of progesterone elevation? How can we explain that? Is endometrium perhaps the likely cause of elevated progesterone? Is there an induction of endometrial changes if progesterone is elevated that should not occur before ECG administration? So what happens if we administer progesterone, utrogestan, vaginally before ECG? Because this would stimulate such a phenomenon. This has been answered by Son in 1999. He administered progesterone on the day of ECG, so before ECG was administered, before triggering occurred, in the one group, and the other one just started on the evening of oocyte retrieval. So this group, in which progesterone was started earlier than ECG, very, very low pregnancy rates compared to the one that progesterone was started on the evening of the day of the oocyte retrieval. So I think it's quite clear. But is there any direct evidence that progesterone elevation on the day of triggering affects endometrial quality? I think there is. We published a study a year ago from Brussels in which progesterone rise was shown to stimulate differently endometrial gene expression. And if you divided patients in different groups of progesterone, then you could see different genes being expressed, which means that this elevation affects endometrium at the molecular level. So it is likely that an adverse effect, what we have observed in this meta-analysis, is probably due to an endometrial effect. Now, I think what is more important for all of us is whether what we have observed is clinically important or is just a theoretical discussion. In order to do that, to understand what this odds ratio 0.64 means, we have to transform the odds ratio to something more clinically interpretable, which in this case is the pregnancy risk reduction. So how lower the probability of pregnancy becomes. And we did that according to the Cochrane methodology. So on the left, we have a chart. On the x-axis, on the x-axis is the absolute pregnancy risk reduction, and on the y-axis is the baseline pregnancy rate. So if, for example, our center has a pregnancy rate of 40%, and we use the 1.5 nanogram per ml as a threshold, in which case we have a 0.64 odds ratio decreased chance of pregnancy, this translates to an absolute risk reduction of 10%. In other words, the patient with progesterone elevation will have 29.9 chance of pregnancy. The one without will have 40% chance of pregnancy. To make it even more clear, if you go to the number needed to harm, you need to treat about 10 patients with progesterone elevation to lose one pregnancy. I will make it more simple. The expected pregnancy rate in the IVF population with a baseline pregnancy rate of 40% according to different progesterone elevation rates when we use a 1.5. So we use 1.5, we have in our center 40% pregnancy rate, but we don't know what will be our rate of progesterone elevation. So in this case, if we have a 40% chance of pregnancy, our pregnancy rate in the IVF center will go down to 38.5. So if we ignore progesterone, say, oh, okay, we will do transfer to all patients, from 40%, our population will go to 38.5. The lowest can be about 37, the maximum 39. So this, it's up to you to decide if this is clinically important or not. Finally, to make it even more simple, if we do 1,000 cycles per year, and we have a 40% chance of pregnancy, and we use a progesterone level 1.5 to define progesterone elevation, then if progesterone elevation is 5%, because we don't do hyperstimulation, we do mild stimulation, we are careful, then we lose 5 pregnancies, so we expect instead of 400, 395. If we have a progesterone elevation of 15%, which is what we expect, then we lose 15 pregnancies per year if we do 1,000 cycles. In other words, in IVF unit with 1,000 cycles annually and 40% pregnancy rate and a 17.2% of progesterone elevation, we'll have to monitor 1,000 cycles because we have to assess progesterone in 1,000 patients, to intervene in 172, which is the patients who will have progesterone elevation, to potentially gain 17 pregnancies. And what does potentially gain means? What are we going to do to gain these pregnancies? Well, the only strategy so far known or proposed to change the course of events is cryopreservation. But there is no prospective randomized study to say patients with progesterone elevation, cancellation of transfer, cryopreservation, we proceed to transfer, and then we compare the two. So we just assume that this is beneficial. Of course, there are several strategies to avoid progesterone elevation, but this means that you have to predict which patients are going to show this. Finally, the last slide, just want to remind all of us something that we, of course, we are aware of, that pregnancy is dependent on several factors, age, oocytes, endometrium, etc., and several others, among which one is progesterone. So we should not, create a big fuss if we show a level of 1.4 instead of 1.6, and we think that the patient will have a dramatically reduced chance of pregnancy. I think that common sense and evaluation of our patient population may lead us to the correct conclusions. Thank you very much.